How's it going, guys? So we have a difficult cardio question for 2CK level. I will tell you exactly what you need to know, not waste your fucking time, and also just give you some factoids with regard to some of these answer choices here. So before we get started, I will be my frequent asshole, tell you to subscribe my channel, I really appreciate it. Give the video a like, really appreciate it. Find me on Instagram at Mehlman_medical, Mehlman_medical, link is down below. Find me on Telegram, recently created a Telegram group and channel, links are down below. Now let's start the fucking clip. So 25-year-old dude, 2-week history, intermittent left-sided chest pain. He describes the chest pain as fleeting. He has no shortness of breath or cough. Uncle had an MI at age 38. Vitals are normal. Lungs are cleared auscultation. Cardiac exam shows a mid-systolic click. No tenderness of the chest wall to palpation. Pulse oximetry 97% on room air. ECG shows no abnormalities, which the following is the most appropriate next step of management. Now, this is a challenging question for me to discuss because we could do a 44-minute oral presentation on every fucking answer choice here, but I'm going to stay somewhat consolidated. Let's just walk through here. Choice A, ambulatory ECG monitoring, also known as 24-hour Holter monitor. Wrong fucking answer. Now, this, however, is super fucking high yield on 2CK for many other questions, albeit wrong in this case. Now, to stay real consolidated, this will be the answer when you have generally an elderly patient over the age of 70 who's had a stroke, TIA, or retinal artery occlusion in the setting of a normal blood pressure, and the ECG is normal. That's going to be over the head of many of you. I understand. I've made other clips on this stuff. But if a patient has a stroke, TIA, or retinal artery occlusion, you have to think, is the etiology carotid stenosis due to atherosclerosis, which would be if the patient has high blood pressure, you do carotid duplex ultrasound. If, however, blood pressure is normal, you say, oh, that's probably atrial fibrillation causing a left atrial mural thrombus that's launched off to the brain. So we're going to do an ECG first. But if the ECG shows no abnormalities, students are like, oh, it's not AFib. Wrong fucking point, because ECG is often normal in AFib because AFib is paroxysmal usually. So patient goes home and has dinner, switches an AFib for half an hour, switches out of it. So you have to do a 24-hour ECG Holter monitor in that case. Long discussion, as I said. Choice B, chest x-ray, wrong answer. Now, this is just a generic, if you don't know what's going on in this question, which we have a mid-systolic click, that's mitral valve prolapse. We're obviously noting that the uncle who had an MI at age 38, that's significant. There's no tenderness of the chest wall. That means it's not costochondritis. They like the MSK stuff that can present similar to cardiac. Pulse oximetry 97% means, in conjunction with the normal pulmonary auscultation, means he doesn't have pulmonary edema. There's no decompensation as far as oxygen getting in. So when we look at this question, we say, well, what are we actually, what's the diagnosis here? I said this was difficult. What's actually going on? This is called mitral valve prolapse syndrome, okay? So I know that sounds really fucking weird. I agree with you. Now, mitral valve prolapse, almost always asymptomatic, okay? It's a benign finding. You could pull 100 people off the street. One person would have mitral valve prolapse. It's like, hey, you got a mid-systolic click. Really? I didn't know that. It's really fucking common, and it's asymptomatic almost always. However, not my opinion, on the 2CK and BME exams, they will assess mitral valve prolapse syndrome, okay? And they describe it as fleeting chest pain, okay? Fleeting chest pain, very buzzy, in an otherwise young, healthy adult. And they can give you a teenager, okay? They'll say, girl, pain under the left breast. She describes the pain as fleeting. They can say 30-year-old male who's had 20 to 30 episodes of fleeting chest pain in the past. He's got a mid-systolic click. That's called mitral valve prolapse syndrome. Now, you need to know that you just do reassurance. You don't have to treat it, okay? Mitral valve prolapse technically could get worse with less volume in the heart. So we could entertain the notion of giving a beta blocker, for instance, where that would increase our preload, okay? But it's the wrong fucking answer. Once again, it's not my opinion. It's USMLE, the NBME. They want reassurance for mitral valve prolapse syndrome. Patients can get pain sometimes, but you don't have to treat it, okay? No intervention is required. Chest x-ray, you're just looking for general pulmonary findings. Enlarged cardiac silhouette, a myriad of uses for a chest x-ray. It's not required in this case. For the echocardiographies, transesophageal is classically done for looking for vegetations for endocarditis. Transthoracic, classically just congestive heart failure, you're looking for ejection fraction, or peripartum cardiomyopathy, okay? General cardiomyopathy, looking for ejection fraction, you do transthoracic. but transesophageal for vegetations for endocarditis classically. USMLE, I actually have not seen them test this distinction on NBME exams. This might be more of a Qbank thing. Okay, they're actually not going to list transesophageal alongside transthoracic and say, holy shit, which one is it? They'll just write echo. Okay, USMLE is actually pretty easy that way. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe my channel. I appreciate your time. That's it.